this off?
Oh, yeah, go ahead.
Okay, good. Because we're going to be able to see his internal jugular real well. And this is a mistake that a lot of people make. Now, the nice thing is that on the other side of the Jaeger, you've got a centimeter ruler. Come on over here, you're going to have some fun. Okay, now, here we go. Ooh, good. I just realized that's a good purse.
Oh, yeah,
Yeah, it's a good purse.
$8, JCPenney. They come in all kinds of different
that's a
colors.
good purse.
And it has
You
a
need
lot of
silver
room.
shoes now.
It's a
Not
lot
like
of room in
Dorothy,
it.
but no, I like them, yeah,
Lot of
okay.
room.
Now, first of all, I just wanted to go over jugular venous distension. Now, John, could you lie back and I'll make you comfortable here? There you go. Okay, good. Now, we can't remove the hat, that's gotta stay put.
Oh.
Now, I'm just gonna actually move your head to the side. Now, there is an external jugular, and you've all seen IVs started in the external jugular? Okay, that runs from the angle of the jaw to the 1/2 mark of the clavicle. So, just gonna go this way. And you can see it pulsing. Now, I wanted to point out that a lot of people use this to measure jugular venous pressure. This is all wrong. If Julian laughs, it's gonna go up. So you end up with JVD measurement because you're happy. If he's on the bedpan, it's gonna go up. If he's in pain, it's gonna go up. Don't use the external jugular because it's not an accurate measure of volume. Do a little party trick for us, would you please?
Okay.
Will you bear down, bear down, bear down, bear down, bear down? Look at this thing go up. See that? Okay, now stop, please. Okay, now, if I was to measure that as his jugular venous distension, I would end up with like a JVD of like 5. Now, we know that he doesn't have heart failure, right, Julian?
I hope so.
You really should ask the patient what they think. Okay, now, let me show you where the internal jugular is. Now, we know that the medial border of the sternocleidomastoid mastoid is part of the anterior triangle. Now, you have a little concavity right there. Now, I want you to look right here. Not you, Julian. Behave yourself. Okay, right there, there is a little flutter. That is the internal jugular, right there, okay? Now, if this was distended, we would see the column of blood evident here, okay? That's where we want to read. Now, his sternal angle, obviously, is higher than the angle or the column of blood here. Now, truly, his head of bed would have to be up at 45 degrees to really measure this properly, but that's what you're shooting for. So when you do the jugular venous distension evaluation for me, you're going to point out where the internal jugular is and you're going to show me how to measure it, okay? So that's my first point for today. Now, if you could sit up,
Okay.
we're going to pretend as if I am carrying on from the head, ears, eyes, nose, and throat, and neck. So I just completed the neck. Now, what I'm going to do is, first of all, I'm going to inspect, and as I watch him breathe, I know that he's eugenic. Now that means a normal rate, and then also his inspiratory-expiratory ratios 1 to 2. That's normal. It takes about twice the time of inspiration to get rid of your CO2. A COPDer would be about 1 to 3. It takes them longer to kind of wheeze out the CO2. Now, the next thing as I go around, because I always start at the back, is I'm assessing his AP transverse diameter. That should be 1 to 2. This diameter should be 1/2 the transverse diameter, and it is. Now, for filming purposes, and so you're really a star, I'd like you to put your knees over here so everybody can see what I'm doing, okay? Put your knees over to your left. the knees to the left. Sit up, the knees to the left. Okay, just switch them around. There you go, yay, Julian. Okay, now, what I'm gonna do, now that I've inspected, is I'm gonna do some palpation. Now this is where, since I'm here, I'm doing an integrated exam. Now Julian, let me know if you have any tenderness. So no cervical tenderness, no thoracic tenderness, no lumbar sacral tenderness. Now we'll get to percussion in a minute. Next thing I can do on palpation is do the fremitus, using the ball of the hand. Now say 99.
99,
Uh-huh.
99, 99, 99, 99, 99, 99, 99.
Now, fremitus diminishes in the periphery. Now that means as air goes through smaller and smaller airways, the vibratory quality of the air movement decreases. So you need to see fremitus decreases in the periphery. Okay, now we're actually ready for the last part of palpation, which is the diaphragmatic excursion. Okay, now inhale, exhale. See how my thumbs part equally? So, chest excursion is definitely symmetrical. Okay, great. Now I'm ready for percussion. Now, the kidneys are located right below 12, T12. So he didn't jump off the table, so CVA percussion is negative. It's not positive. Okay, now I'm actually going to percuss the lungs. And you notice how I'm finishing everything here and I'm combining several things? So I did a renal test, I did musculoskeletal, and now I'm going to do percussion. Now here's the point. This is T1, T2, T3, T4. It's kind of amazing. Everything above here is the upper lobes. Everything below will be the lower lobes. So the apices are like little half moons like this. So to best percuss those, now look what I'm doing. I'm going to hyperextend my finger, and then I'm going to tap with 2 fingers. That's resonant. So it's 3. Now this is dull. Kind of rocky. Okay. So that's percussion. Now, next thing is that below the label, I want to make sure that I get my finger in between the ribs. Now, posteriorly, they are like fish bones. So I don't want to see anybody doing this. That dulls out your sound. Now, when you get down to right below the scapula, the ribs are not so slanted. They're a little bit more horizontal. So you'll notice that I changed the position of my hand. Now listen carefully. That's resonant. That's resonant. 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 Okay, now, taking a deep breath and hold it. Tell me when the sound changes.
No, right there.
Right there. Okay, exhale. Okay, now, breathe. Now, his diaphragmatic excursion was about 3 to 5 centimeters. So what did I just do? When he inhales, the lung gets bigger. And then what I did is I percussed down, so I established the lowest point. As he exhaled, the lungs rose, or they got smaller, and so you notice I just backtracked until you heard the sound. So this is the right. So if the right goes here, we know the left will go lower. So I just want you to percuss adequately up here, and then show me diaphragmatic excursion here. Now the maneuver again will be, inhale please. That dulled out. Exhale. Okay. Yeah. So that's how you do it. Now listen. Vesicular, vesicular. Bronchovesicular. Vesicular sounds have a ratio of 3 to 1. They're very soft because they're small airways. Bronchovesicular sounds are IE ratio of 1 to, not IE ratio, but the ratio is 1 to 2. It is actually IE. 1 to 1, I'm sorry. They're medium pitched. So those are normal posteriorly. So can you take some breaths through the mouth, please? Okay. So these are vesicular sounds, 3 to 1 ratio. These are louder, 1 to 1 ratio. Bronchovesicular. Vesicular sounds, 3 to 1. Okay. So there are no rawls, no crackles, no wheezes. Now, if you suspect that somebody has a pneumonia, then you can do a gophony or any of the voice sounds. I think I would like you to do a gophony because you'll remember that. So Julian, could you do me a favor, since